So I'm Tim Craig. I'm from Penn State University, and I'm here with my friends and colleagues, Aleena Banerji, who is from Harvard Medical School, Massachusetts General Hospital, and also Marc Riedl, who's from the University of California in San Diego. We did a tri-X where we looked at the general population and then studied that to people who have been in studies in phase 1, 2, and 3 research studies. And you can see on the one chart here, it shows you that almost all the patients who are in clinical trials are Caucasian, and usually not Hispanic-speaking Caucasians. And when I mentioned the figure before, it's close to 90% in most cases. And if you look at the difference between the rate in the population of HAE and the rate of patients in clinical trials, actually that percentage is higher in Caucasians as compared to the in clinical trials as compared to those in the general population. But if you look at Blacks, you look at Spanish-speaking individuals, and if you look at Asians, very, very few are in any clinical trials, much less than the HAE in the general population. So that's a problem somewhat because are the data we're collecting, are they equal between the different races? We don't know. We assume that's the case, but almost everything's based on all the efficacy and side effects are basically based on Caucasians. When you look at it a little different too, somewhat we can show, we've looked at drug responses in different races. And this was a study done with Takeda. And we looked at the HELP study, which is the lanadelumab study. And if you look at the data carefully, you can see it looks like, at least in the first part of the lanadelumab study, it looks like that actually Hispanics responded much better than Black or Asians or Caucasians. But if you look at these numbers, there was only like 2 Asians. There was only a handful of Hispanics and only a handful of Black people. So how do you really tell if that's in fact the case? So we looked actually into the HELP study in the long-term open label part, and you could see similarly that there seemed to be somewhat changes. But I really do think doing the open label, it made it likely that these drugs, at least lanadelumab, is just as effective in minority groups as it is in majority. But still, it would be nice to have more Asians, more Black Americans, and more Spanish-speaking people in the trials to ensure that's the case. Now, I guess either one of you have any comments in the same sense of disparity in clinical trials and also the disparity in responses to medications?
Just to quickly review that claims database study that I mentioned earlier, but now look quickly at the ethnic and racial groups. And again, this was looking for disparities amongst these different race or ethnicities. So remember, if you look at the claims for long-term prophylactic HAE treatments, so these would be prescriptions for the long-term prophylactic therapies, you'll note that across the board, the outlier here is in the African American population. At least numerically, there were many fewer claims for long-term prophylactic therapy compared to the other ethnic groups, and certainly below the overall mean percentage. You'll also note that small bar in the box, again, is a consultation with an allergist immunologist, and so a much lower rate of seeing an allergist amongst the African American population compared to other groups. Similarly, for FFP, that older treatment for HAE attacks, much higher prevalence or percentage of prescriptions or claims for FFP in the African American population compared to the other groups. And lastly, looking at the odds of having an emergency department visit. This was statistically significant, the odds being much greater in the African American population and greater also in the Hispanic population compared to the other ethnic groups. Now, we don't know if those HAE visits were, or sorry, those ED visits were for HAE specifically. So there could be other factors leading to that odds ratio being much higher. But nevertheless, this is a statistically statistically significant difference in where people are seeking their care amongst these different groups. Well, I think as you said, Tim, it's hard to draw any firm conclusions from comparing such small numbers, especially for these underrepresented ethnic groups. There's no question that we need to better include those groups in clinical trials, because as you said, almost all the studies are far predominantly in whites. So we need to continue to recognize this and make efforts to, to be more inclusive as we do clinical trials. The interesting thing is that, as you know, but it's important to state that as far as we know, there is no ethnic HAE plays no favorites when it comes to race or ethnicity, right? It affects all different races around the world, and interestingly, in pretty similar prevalence, regardless of which country you look at. So this is really, I guess my point is this is a systematic issue, right? It has something to do with who's interested in studies, how are we presenting it, who's given the opportunities. And so it's something that we should hopefully be able to address in the future to get better data, more representative data.
Yeah, and that's true. Like in Vietnam, there's supposed to be 2,000 people who have HAE, and we only know a few handfuls. And, somewhat just social, I talked about, if you don't have medications, are you really going to go to the hospital? And, there's nobody knows if they have the disease or not. So it's really difficult, especially since you don't have the functional assay, but it is a major problem. And it's also hard to do research in a lot of countries. We've tried to have some research on HAE in Vietnam, but the national restrictions are so difficult to really perform studies there. It makes it almost impossible.
And I think these are challenges in clinical trials, not only in hereditary angioedema, but we see this in a lot of data in many, many clinical trials and many different clinical conditions. And I think that recognizing this and actually understanding how can we impact these communities or these ethnicities and why are they not participating? Is it lack of trust? Is it a cultural belief? What are the barriers? And then actually spending the energy and the time to address it is going to be important going forward.
So with the time element that we have right now, if it's okay, I'll summarize everything in just a few minutes, and then we'll open it up for final comments. So I think we looked at disparity. It occurs in race, it occurs in countries, it occurs in urban and rural areas, and less in urban, but definitely rural, as Marc talked about. This has a problem in the sense of people get inadequate care. It has a problem in the sense of having emergency care in emergency rooms that don't have the medications. Maybe in those populations, at least in the rural, in high-income countries, there may be a greater reason to, discuss prophylaxis. Well, you should discuss prophylaxis at every visit, but maybe have that person on prophylaxis and encourage it because their inability to get good emergency care. In addition, I think in response to that is education of patients, making shared decision, making sure people have some kind of identity card on them that helps emergency room physicians, have a center, maybe see the patient on a regular basis, maybe once a year or maybe every 6 months to ensure that the patient's up to date in their medications. And, again, going back to the HAE, having patients introduced to HAE so they can reach out. So I think we have a lot to do about correcting disparities. I think, as Aleena, you pointed out, just the fact of discussing it is very critical in collecting the data so that we can react to it and see how we can improve care of patients who have HAE. And in fact, as again, Aleena, you pointed out, it's true for almost all rare diseases, have that same issue that hereditary angioedema patients do. So Marc, Aleena, you have any closing comments?
Just to highlight that this remains a very important issue, and I think that we need to continue to collect data, raise awareness, and actually put forth a lot of effort to understand the reasons behind these inequities and how best we can make an impact over time.
Yeah, and I'll just add, I think these are complex issues, right? There's, as you said, Aleena, this it's going to take energy, it's going to take resources, but recognizing that this is potentially occurring, and the data we have is insufficient to really answer the question, but it sure looks like there are these disparities out there in rural areas, in certain ethnic or racial groups, and so. As I think you said earlier, we're talking about it. That's important. Should be just the beginning to recognize these are challenges we've got to tackle, and then putting our heads together and finding some solutions and opportunities. So I look forward to more programs like this and more studies that we can report that'll hopefully solve some of these problems or at least improve the status quo.
Good. Hey, thank you all so much.